everyone. So my name is Dr. Neha Saxena and I'm one of the mentors in the StudyMRCOG group. So today I welcome you all to another series and the episode of our series that is Back to Basic YouTube series for the preparation of the upcoming Part 3 MRCOG exam. I hope you all are doing great and you all are in full swing and your preparations are going on in full swing as well. I hope all are having the templates and all are having the practice sessions that we do on a daily basis. This series, my dear friends, is made so that you have a short video of what to prepare, what important topics are there in a particular module, and how to prepare, what are the do's and the don'ts that you have to follow importantly during the exam time. So let me start the session without any further delays. So I welcome you all to the next module of discussion, that is the core surgical skills. So here, my dear friends, first of all, I would let you know what type of questions would be asked in the module. This is a very, very important module, and this has to be one of the stations that you will face during the exam out of all the 14 stations. First of all, what type of cases we can get in this station? First one is taking of a consent, right? So as we all know, we'll be giving in a consent form. It can be a structured discussion. Usually the consent will be a structured discussion to you all. Okay, so one paper of consent would be given to you and you will be asked that you have to take the consent of a particular procedure. So ensure that this is not a teaching station. You do not have to teach or tell anything to the role player. You have to discuss the role play with the role player. You have to tell about the intended benefits of the procedure, the advantages, risks and the complications, and with the help of the pencil that you would be given in the exam, my dear friends, you all will have to fill the consent form simultaneously when the discussion is going on. I see a lot of candidates, they are just discussing with the role player that this is the consent and these are the advantages, these are the complications and what are the additional procedures required, etc. But they do not write in the exam. So this is a very important tip for you all during the exam, that when the consent form is given to you, you have to pick up your pencil, you have to ask the name of the role player, and you have to start filling that consent form in the exam. Okay, so now the consent taking can be of any topic. There are unlimited and countless topics that I can give you for the consent. The most commonly found topics in the exam that you would be seeing would be, first of all, the consent for hysterectomy. The hysterectomy can be vaginal hysterectomy or a consent for abdominal hysterectomy, or it can be a total laparoscopic hysterectomy or any laparoscopic hysterectomy or procedures. Okay. Next would be the cesarean section. You can be given any case of perineal repair. Any laparoscopic surgeries can be there in the exam. For example, a young girl who's coming for a ovarian cyst and then you have to take the consent for the ovarian cyst, or removal of an ectopic pregnancy, or any other procedure like the termination of pregnancy, where you have to tell her about the surgical management of the termination of pregnancy and how will it be done. Okay. So the next type of cases that we usually find in the core surgical skill modules is a very, very important topic of discussion. That is, my dear friends, enhanced recovery program. Okay. So this has to be one of the questions in the exam. Enhanced recovery is such an important topic that it has to be on your tips, starting from the referral from the GP to doing a pre-anesthesia workup and check, going into the hospital from the pre-op, intra-op, post-op, and the follow-up period. So this station or this flow of the diagram has to be on your tips, because it is a very easy station and it is a good station to grab on perfect marks for you as well. because see, you cannot go wrong with these stations, right? Because they have got like fixed protocols, minimal invasive surgeries, ruling out allergies, checking for the comorbidities, etc. and etc. Okay, so these are the stations that you have to keep on your tips, because these are the mark snatching stations in the exam. For example, one station did not go very well for you, and the next station you find that it is the enhanced recovery station. So you have to modify the station in such a way that you compensate for the losses that had happened in the previous stations. Okay, so it is a very straightforward station, and therefore this is an enhanced recovery station for you, where you can just grab one perfect marks in the exam. Okay, this can come, my dear friends, as a structured discussion where the examiner will be asking you a few questions about what exactly you will do in the enhanced recovery, or it may be a discussion with the patient. If the patient is coming to you, what exactly you'd be doing now, doctor? When will I be getting admitted, etc. Usually what I have seen that you get a structured discussion in this as well. Okay, so you have to prepare yourself to the fullest so that you do not lose any mark in this type of station. Okay, the third one we'll be dealing with some intraoperative complications. For example, it may be any complications, like you're doing a cesarean section or you're doing a laparoscopic surgery, and then you find that there's a leak of urine. You suspect any injury of the bladder. You suspect any injury of the ureter. You suspect any bowel injury, or you suspect any vascular injury while you are entering the laparoscope. Okay, so, and most importantly, the nerve injuries that during the hysterectomy, obviously the nerve injury stations would not be emergency stations, because the nerve injury would be appearing later on. However, the other three, that is the bladder, bowel and the ureter injury, it will be given as a intraop complication where you have to deal with the management part of it. Okay, so other miscellaneous type of stations that we can see during the core surgical skills module or the stations would be the instruments. Okay, we have got another session for you where we'll be showing the instruments and the suture materials, etc. Okay, so the instrument that we usually encounter during the exams would be the hysteroscope, the laparoscopic instruments, and the vacuum, the forceps, along with miscellaneous instruments like the speculum, the Utri forceps, the Babcock's, or the Alice forceps, or anything like that. Okay, so these are the very practical stations that you have to do so that you do not lose any mark over these type of stations, right? The type of stations that we see would be the stations related to the suture materials, where the suture materials may be put and they might ask you what type of suture material is this, and where exactly would you be using the suture materials, the indications, the contraindications, etc. Okay, then they can ask you about the types of abdominal incision while any station is going on. For example, in structured discussion, they may ask like what type of incisions are most commonly used, and what are the advantages and the disadvantages of transverse and longitudinal incisions as well. Okay, also a very important part of discussion would be the laparoscopic entry techniques. For example, if they say that the patient is obese, where will you put your primary port? Okay, so this station might come as a structured discussion also, and in SPT as well. Okay, so this is the overview, my dear friends, that these are the usual stations that you could find in the exam when you are having a cubicle for core surgical skills. Okay, however, it will not be mentioned that we are dealing with the core surgical skill module obviously in the exam, but you have to see what exactly topic is asked from. Right, hope the session is clear to you till now. Now we'll be heading towards what exactly we have to do or approach when such station come, and what we do not have to do when the station comes. Okay, so first of all, let me take you through the consent, where I would tell you what exactly you have to do when such a station comes. So first of all, you have to read what exactly the station is demanding. So those 2 critical minutes of reading time is very important, my dear friends, in exam. Yeah, so here you would see or you would read what exactly they are asking you. whether they are asking you the structured discussion part or whether they are asking you actually to take the consent, as I already discussed that, right? So you have to categorize and see what exactly you are supposed to do in those 10 minutes inside the cubicle, okay? You have to introduce yourself and give a sweet greeting. Then you have to take the paper of consent in your hand and ask about the name of the patient, and you start scribbling, okay? Just note the name of the patient, the NHS number, the age of the patient. Not too much writing part, only you just have to scribble so that quickly you take the procedure, the consent of the procedure as well, and you start filling as well, okay? You have to specifically see what is the name of the proposed procedure, and in the form you have to write the name of the proposed procedure. For example, abdominal hysterectomy, right? After that, the consent, while you're talking to the patient, it has to be informative, it has to be understandable. You do not use medical jargons there. It should be reproducible by the patient, that the patient is understanding, and then only the patient is signing, okay? You have to see that in the consent, you have mentioned what are the intended benefits of the procedure. For example, if the patient is to be posted for an abdominal hysterectomy, you need to tell her that the benefits would be that the bleeding would stop forever. Usually the hysterectomy part is done because of fibroids or abnormal uterine bleeding. Okay, what are the risks associated? Some serious risks and some frequent risks. For example, bleeding might be there, anesthesia complications might be there, infections, prolonged immobilization, morbidity, mortality, etc. Whatever is given in the question, you would remember 2 or 3 serious or the frequent risks, and then you can just tell to the patient in his or her own words, avoiding any medical jargons. Okay. After that, you have to write 1 or 2 complications like bleeding, infection, pain, etc. in the column, which is given perfectly for the complication part, right? Then, my dear friends, what exactly we do not have to miss? First of all, these are the type of stations which the patient or which the candidate is not usually able to understand, okay? In such type of stations, I would advise that please do not panic. Right? Everything is very clearly given in the instruction part, and then you enter into the cubicle, and then you face that consent form is written, consent form is put here, the pencil is put here, what exactly I have to do. So in that situation, that's why I'm saying those 2 minutes are very important, that you need to read what exactly they're asking you. Okay? No medical jargons, explain the consent in very simple language to the role player, okay? You have to ask or you have to address his or her concerns as well. It is not that you are short of time and you are busy in writing and filling up the consent form. Even if you're not able to completely do that, usually the consent form does not take very long. You will be able to finish the station in approximately 7 to 8 minutes, because it is just you have to discuss it with the patient and you have to keep writing, okay? However, if the patient stops you or the patient is asking you something, please address whatever the patient is asking, or please address his or her concerns, right? Never ever interrupt the role player because you are in a rush to finish any station, okay? So I hope this consent thing is very clear to you all. Coming to the enhanced recovery, what exactly you have to mention here? You have to specifically mention the enhanced recovery, not from the intra-op, not from the admission to the hospital. You have to, without fail, start the enhanced recovery program right from the referral from the GP. Okay? Then you have to see the comorbidities. You have to rule out any diabetes, hypertension, thyroid problem, obesity, etc. You have to see whether she's on any medications like OC pills, whether she is smoking, she is alcoholic, or any other medication that she's on, right? You have to take her through the proper workup in the preoperative period by ruling out comorbidities, asking for drug allergies, and going for an examination by the anesthesia specialist and getting an anesthesia clearance done as well. Okay, because once you do all these investigations and the anesthesia workup, it is absolutely okay that we reduce the hospital stay of the patient, because the patient would be admitted on the day of surgery. Okay, and that is the essence of our enhanced recovery, that the recovery of the patient is pleasing, the limited hospital stay is there, and the patient is discharged early as well. Okay, also you have to mention specifically what will you do when the patient is admitted and when are you going to admit the patient. If you're going to admit the patient 2 or 3 days prior, then that will be a blunder, my dear friends, in exam. You have to say that I will be admitting the patient on the same day of surgery, and then you will be confirming the allergies, you will be confirming the pre-anesthesia checks have been done, you will be seeing whether the consultant has seen, you will be advising the minimal invasive surgeries, etc. Okay, you will have to see whether the consent procedure has been done prior as well or not. Taking the patient through the intraoperative period, taking the patient through the post-operative period, and importantly, my dear friends, most of you forget that the patient has to be discharged, and after discharge, the patient has to be called for a proper follow-up. If you not have all the patient for a follow-up, then that will be a straight negative marking, because enhanced recovery is not only finished when the patient has had his surgery or her surgery, it will be ended when the patient has completely been seen and he has recovered from the post-operative period till the time you have discharged the patient and till the time the patient has come for a follow-up. Okay, so you have to take the patient till the time the follow-up is complete and when you have discharged the patient to the care of the GP back to the community. Understood? Then what exactly we do not have to miss in the enhanced recovery? First of all, we cannot miss the pre-anesthesia workup. We cannot miss the adequate history part, like ruling out any comorbidities, any addictions, any medications, and ruling out any allergies. Okay. Then we have to advise that the enhanced recovery program says that minimal invasive surgeries are preferred in surgeries where you can go for the laparoscopic techniques as well, right? For example, if the patient is posted for abdominal hysterectomy, you have to see whether in the consent alternative methods of hysterectomy, for example, the vaginal hysterectomy, the laparoscopic hysterectomy, or the medical management, etc., have been given and been discussed with the patient or not, right? And then after that, you have to see the follow-up as I already discussed. Okay, enhanced recovery is never ever complete without the discharge part, without the follow-up part, and it would end at that point where the patient has already started, that is from the GP back to the community, back to his GP. Okay, so these are the things that you have to specifically see in an enhanced recovery thing. Now coming on to deal with the intraoperative complications. So what exactly we will see and how will you manage any intraoperative complication that has happened? First of all, for example, I will give you a case scenario that you are doing a cesarean section and you are seeing a lot of vascular channels down there. Okay, so what exactly will you do? First of all, you will call for help, right? The next scenario that I would give you, that you are taking a patient for the cesarean section and when you open the abdomen, you see the urine leak and you suspect that you have injured the bladder, right? It may be an obstetric case, it may be a gynae case, it may be any complication, it may be any case that they can give you. Okay, so first of all, immediately call for help, because at an ST5, we are not supposed to deal with all these complications ourselves. Okay, you have to inform the team, you have to involve the multidisciplinary team as per the scenario given. For example, the OT in charge, the anesthesia specialist, the blood bank specialist if required, the consultant on call, and any other relevant specialities, for example, the urosurgeon, the colorectal surgeon, or the general surgeon for that reason may be involved in these type of situations. We have to see whether the patient is in regional anesthesia or general anesthesia, because if the patient is in regional anesthesia, then the patient would be listening to our conversations, and that may add to the anxiety of the patient, which we do not want. Okay, so we have to be very calm and composed. Because of the complication, many times it happens that we are panicking, and because of that situation, the patient can also get panicked. This is a very important patient safety point, my dear friends. So please remember that you mention in such a way that the complication is also dealt with, the team is also there to help you and support you, and the patient is not unusually frightened, right? That time that the consultant is coming, if possible, just secure the bleeding edges if there are any, okay, without causing any further harm. After the procedure is done, after the complication has been managed, please mention about the very, very important points which most of you fail to do. Yeah. So what are these points? These points, my dear friends, are the clinical governance points. You have to tell, you have to document what exactly happened, why it happened, how it happened, and you have to give the clear documentation in terms of the date and the time and the procedures involved. Okay, who were called, what was done, and now you have to see what exactly medicines would be given and how the patient would be managed post-operatively. Okay, along with the documentation, after the patient is shifted from the operation theater, you have to debrief. If the patient is fine, you can debrief the patient, or if the patient is not in a state of understanding anything because of the anesthesia and the stress of the procedure, you can discuss it with the partner or any caretaker that the patient has come with. Okay, duty of candor has to be there. Apologize, say sorry. Okay, even if you know that it was not your fault and it was bound to happen, please and please apologize and say sorry, such complication has arrived. However, it has been taken care of well, because as I already told you that you are admitted under a team of specialist doctors. Okay, so by that saying that, the role player or the relatives are very ease and they will be able to understand the situation better. Yeah. After that, you have to fill the data or the incident report form. You have to see whether the DVT prophylaxis, that's the pneumatic compression devices, etc., has been done for the patient or not, because it was a long procedure now to deal with the complication. Yeah. And then you have to specifically mention the discharge performer. You have to specifically mention what exactly had happened, the series of events. And at the time of discharge, you have to tell about the care. For example, if the patient has had bladder injury or ureteric injury and you are discharging the patient with the catheter in situ, please see that the catheter care, the continence nurses, the physiotherapist, and the community midwife have been informed, and home visits or hospital visits have been advised to the patient or not. Catheter care has been advised to the patient or not. What are the red flag signs? Like the kinking of the catheter, no urine, bloody urine, blockage, etc. Okay, give 24/7 numbers as well. Without saying these things, my dear friends, the station of dealing with the intraoperative complications is never and ever complete. Okay, give a clear follow-up plan, as I already told you, along with the 24/7 numbers and the red flag signs. And please inform the GP that such a thing has happened and we are sending the patient back to the care, and then we have advised the follow-up timing of that sort, etc. So the GP has to be informed so that he also takes into consideration the patient condition and he also arranges for some help if required by the patient. Okay. Now, coming for the don'ts part of it, first of all, as I already discussed, please do not panic, because that's a situation where we do not understand at times like what exactly is to be done, and we forget that the patient is able to hear everything. Yeah. So that is a very important patient safety point, that we do not have to frighten the patient up in case any complication has happened, and do not become suddenly a hero and start proceeding for the complex procedures. Okay, because that, my dear friends, is a very, very important patient safety point. In our usual practice, we are practiced and we are competent enough to deal with a lot of complications ourselves without involving the MTT and the specialist team of doctors. However, in the exam, when we are presenting, we are going as ST5, and the ST5 does not have all the competencies to deal with the complex procedures. Okay, so you have to tell that I will be stopping and I will be calling for help, and you do not have to proceed unless and until the consultant is available. Okay, you cannot miss the 6 Ds of the clinical governance point that I just mentioned, because without that, you will straightforward get a borderline in patient safety and in communication part as well, and also in the applied clinical knowledge. And we cannot afford to do such a big blunder in any of the stations during the exam. Especially, it's a very straightforward thing that if the complication has happened, you have to follow the 6 Ds of the clinical governance point without any fail. Okay. So how would be the domains be marked? First of all, most important domain, that is a patient safety. First of all, recognition of injury is very important. Do not neglect if you are seeing a gush of fluid or a gush of urine and you are neglecting this. Okay, this might be some peritoneal fluid, right? So identification of injury is one part. They may give different scenarios and they may ask you in the exam what exactly you think it might be. Okay, so that recognition of the diagnosis is very important. Okay, doctor, I feel that she is having a complication of ureter injury or a bladder injury or etc. things. Okay, so you have to give the differential diagnosis unless and until the diagnosis is very clear on clinical examination and on the investigations that have been done. Okay, you do not, the examiners do not expect you to give the exact diagnosis, but by the history part, by the things that are happening in front of your eyes during the intraoperative period, you have to see what exactly has happened. Okay, you have to involve the MDT. You have to do the timely management as well. Okay, for example, the need for immediate treatment by calling the consultant and closing the bladder or taking care of the bleeding vessels. And then you have to advise the close monitoring of the patient to prevent any complications as such. The second domain would be the information gathering. In all the stations, quickly, obviously, when the intraoperative thing has happened, then you cannot go for the detailed information gathering. But then you have to ask that, I would just ask my midwife or I would just ask my colleague to just see whether he's allergic to some medications, whether Jehovah's Witness has been ruled out or not in case he or she requires any blood or blood products. Okay. And only the comorbidities have been taken care of. Okay. In case you are taking a consent, information gathering becomes a very important part of the discussion, my dear friends. And you have to see that I would like to gather some information from the patient. For example, what is the medical history? What is the surgical history? So that I decide how to go about a particular case. Okay. Also, you have to rule out any pregnancy in case you are posting a patient who's in the reproductive age group. Because you know what happens that we have taken a consent at one time and the procedure is scheduled for the other time. So in that situation, we might miss on the pregnancy part as well. Okay, so it is very important that we see whether the pregnancy has been ruled out or not. Okay. After that, you have to inquire about the symptoms, like asking the detailed questions about what the patient is presenting with. You have to see the clinical examination. For example, in case of any intraoperative complication that has happened, you have to see what are the vital findings. Okay. What are the investigations in case previously done, or what would you want to offer the patient now? Okay. In case you are posting any procedure, then you have to see whether any addictions have been ruled out, whether the patient has been seen and has been told about stopping of important drugs, for example, the oral contraceptive pills, stoppage of smoking at least 4 weeks prior to any major surgery, right? The next domain would be the communication with colleagues, where you have to involve the MDT, my dear friends. So this is a very important point where you have to involve the MDT, and you have to give a clear instructions of how to manage this particular case with your consultant. Okay, so communication with colleagues would come with the multidisciplinary team. So MDT has to be involved where any complication has happened. Okay, then coming to the applied clinical knowledge, definitely the applied clinical knowledge would be discussed as per the case that we are dealing with. For example, if we are dealing with the consent procedure, then you have to see the benefits of the consent, the risks mentioned, okay, and what are the alternative procedures? Have you explained that to the patient? What are the additional procedures would be done? For example, the need for blood and the blood products, whether the consent has been properly signed with the date and the time as well. Okay, in cases where we are posting a case for the surgery, as I already discussed, you have to see the comorbidities, and all the aspects of enhanced recovery have to be mentioned here, right? The management protocols, like how will you exactly go about the procedure, what would be the procedure be, and in case any complications happen, what exactly you will be doing to deal with the particular thing. What are the complications you have to specifically mention of, especially in cases where we are doing a consent procedure, and also when we are doing the injury stations. Okay, so you have to tell that the recovery would be slightly delayed, the catheter would be there in C2, and we can just expect a few complications like UTI, etc. However, the long-term complications would be less and remote. Okay, it depends upon the case scenario that we are dealing with, my friends, right? And as I already told you, applied clinical knowledge would be straightforward, fail, or borderline if you do not involve the 6 Ds of the clinical governance points. Okay, so these are the domains that you would be checked on in surgical skills or in any station. For your reference, this is just a consent form, and such type of consent form would be given to you in the exam. So quickly go through this consent form, and if you want to practice, then you can just take a printout of this form, sit with the role player or any friend of yours, and just start filling the consent form. So that mentions the name of the patient, the date of birth, and its number, what is the job titles, etc. What are the name of the proposed procedure, okay, and what are the extra procedures, what are the complications, right? So these are the things that you need to look upon. Okay, you have to mention the frequently occurring risk, and you have to mention about the intended benefits as well. You have to not miss the signing part. You have to sign yourself, and you have to give the patient that please sign this if you have understood everything, and can you just repeat 1 or 2 things for me, so that you have confirmed that it is reproducible as well. After that, you have to mention the date of your exam and the name, like the signing and the name part. Okay, in the cases you are confused, then you just take the printout, read the consent form once, because this was my exam question as well. So in the cubicle, honestly, I did not know what exactly is to be done. How do I write it? Do I need to write it? Do I need to only discuss it with the role player? So I was absolutely confused. Howsoever, I managed to pass my exam, so I must have done a good job only. So my dear friends, this was the end of today's episode of Back to Basics. I hope this session was absolutely clear to you, and you are very through of the do's and the don'ts and the important topics that you need to cover in the core surgical skill module. In case, my dear friends, you have any doubts, we as a team are always available to help you and guide you as the exam is approaching nearby. In case you have any doubts, you are always welcome to call us and connect to us anytime. Thank you, my dear friends, for giving me your precious time. I hope this session was informative to you. In case you have any doubts, please let us know. Thank you so much. Have a happy learning. Have a great day ahead. Thank you.